Assalamu alaikum. My name is Noor Saleh. Me and my colleagues made a seminar about the cerebrospinal fluid. Cerebrospinal fluid description. Cerebrospinal fluid is a clear, colorless fluid formed within the ventricles of the brain. The choroid plexus produces about 70% of the cerebrospinal fluid. The ependymal lining of the ventricles and cerebral subarachnoid space produce the remainder. About 500 milliliter of the cerebrospinal fluid is formed per day. Reabsorption of the cerebrospinal fluid occurs at the arachnoid villi. The volume of the normal cerebrospinal fluid differs in adults from the children. In adults have average from 90 to 150 milliliter, while in children from 60 to 100 milliliter. The appearance of the normal cerebrospinal fluid is crystal clear colorless, and the pressure is from 90 to 180 mmHg. Total cell count essentially is free of cells, so any appearance of other cells mean other defined. The white blood cells is from 0 to 5 white BC per microliter. Red blood cells in the normal cerebrospinal fluid has limited diagnostic value. Specific gravity is from 1.006 to 1008. Glucose is from 40 to 70 mmHg per deciliter, while the protein is from 15 to 45 milligram per deciliter. The pH is from 7.28 to 7.32.
Hello everyone, this is my name is Mai, and I'm going to talk about the CSF circulation. The cerebrospinal fluid is produced by vascular bulges called choroid plexuses. The choroid plexuses are located in the lateral ventricles and in the roof of the third and fourth ventricles. The circulating CSF flows from the lateral ventricle to the third ventricle, passing through interventricular foramina, and then to the fourth ventricle through the cerebral aqueduct. From the fourth ventricle, the CSF either continues to the central canal of the spinal cord or leaves for the subarachnoid space by passing through the medial aperture and lateral apertures in the roof and lateral recesses of the fourth ventricle, respectively. The fluid then flows through the subarachnoid space surrounding the brain and spinal cord. It finally leaves the subarachnoid space and CNS by entering the venous sinuses through the arachnoid granulations. And now I will leave you with this short video.
Hi, my name is Amani Hmaidan, and I am going to talk about CSF function. Starting with the buoyancy, we have two important functions to mention here. First, CSF makes the brain float in the skull without pressure, and that is very important to the brain. Second, whenever the head is getting hit by any external force, the brain is protected by CSF. This occurs by reducing its weight from 1,400 grams to about 25 grams only. The second function of CSF that it removes waste products from cerebral metabolism and also play a role in providing nutrients to the brain. Lastly, CSF is important in diffusion of signal molecules like neurotransmitters transport. What about clinical applications? CSF is used for diagnosis of four major disease categories: A. Meningitis, B. Suprarachnoid hemorrhage, C. CNS malignancy, like meningeal carcinoma and tumor metastasis, and D. Autoimmune disease and multiple sclerosis. CSF also used for determine level of CSF pressure, introduce anesthetic and drugs, radiographic studies and nuclear scans, and lastly, CSF used to identify extent of brain infarctions or stroke. Now, my colleague Mariam Walid will continue. Thank you.
Hi, my name is Mariam Walid and I will talk about how to prepare the patient for lumbar puncture. First of all, the referring physician who performs the test usually explains the purpose, benefits, and risk of lumbar puncture and explain tests to be performed on CSF specimen. Patients are not acquired anything special before coming for the test. There are no dietary or food restrictions except in general anesthesia. We need to make sure that the patient doesn't have any contraindications and ask the patient if he has any allergies or adverse reaction to medication like warfarin, which obviously increases the risk of hemorrhage. For female patient, ask her if she is pregnant or may be pregnant to determine the exact level of the puncture. Some patients will be asked to have a brain scan, CT or MRI performed prior to the procedure if never had one before. And finally, help the patient to relax by having him or her breathe slowly and deeply. The position, there are two types, which is lying position and sitting position for adult patient. For an infant or young child, someone will hold the child in the position during procedure. Your back is washed with antiseptic soap or iodine and covered with a sterilized sheet. After the procedure is completed, we tell the patient to lay flat for about half hour and give him something to drink, which is very important to rehydrate. There is a two type of position, lying position and sitting position.
Hi everyone, my name is Isra Abdul Munam. I will explain how to collect CSF sample. CSF can be obtained by lumbar puncture, ventricular aspirate, subdural tap, and aspiration from ventricular shunt. For lumbar puncture, it has indication and contraindication. Indication are diagnostic indication and therapeutic. Contraindication are increased intracranial pressure, local infection, papilledema, and coagulopathy. To do lumbar puncture, we need a spinal needle, which is available in an array of sizes, 60 to 30 gauge, length, and tip design. Spinal needle consists of two parts, needle and stylet. It is tightly fitting removable stylet to avoid tracking epithelial cells into subarachnoid space. A spinal needle has two broad groups. First, sharp-tipped as a quick needle, which is a cutting needle with the end injection. Second type, blunt-tip needles, as Whittaker with rounded point and side injection, and Sprout with rounded point and long side opening. For lumbar puncture, place the patient in side-lying position or sitting position with the head flexed to increase the space between the lower lumbar vertebra so that the spinal needle can be inserted more easily. Select the puncture site, usually between L3, L4 in adult and L4, L5 or lower in small children. This video shows the procedure of the lumbar puncture. First, sterilize the area of the puncture in circular movement. Then, select the puncture site between L3 and L4 vertebra. After that, Inject anesthesia slowly into derm around the intended site, as we can see in this video. After that, insert a spinal needle with a stylet into the midline between the spines of the lumbar space and slowly advance it until it enters the subarachnoid space. Remove the stylet with the needle remaining in the subarachnoid space and attach a pressure manometer to the needle to record the opening CSF pressure. It is an important point in the procedure. Remove a specimen consisting of up to 20 ml CSF. Take up to 4 samples of 2 to 3 ml each. Place in separate sterile vials and label sequentially. Finally, specimen of CSF must be immediately delivered to laboratory. And thank you for listening.
My name is Masara. I would talk about complications of lumbar puncture. The complications include the following: headache, low backache, infection, herniation, hemorrhage. CSF pressure. The CSF pressure is directly related to pressure in the jugular and vertebral veins that connect with the intracranial dural sinuses and the spinal dura. It is measured during lumbar puncture using manometer. The method of measuring. Once the lumbar puncture needle is correctly inserted and the CSF is obtained, attach the manometer to the needle. It will take 1 minute to CSF to be measured. An increase in pressure may be due to meningitis or intracranial tumors. Decrease in pressure may be due to circulatory collapse or severe dehydration.
Hi, my name is David Behnan. I will talk about examination and diagnosis of CSF. For examination, we take 4 tubes, 2 to 3 milliliter each. Tube 1 for chemistry and serology, Tube 2 for microbiology studies, Tube 3 for hematology cell counts, Tube 4 for special studies. Notes: in traumatic tap, Tube 3 must be used for maximum test. Never use Tube 1 for microbiology to avoid contamination with skin bacteria. As you know, after the sample taken from the patient and collected in 4 test tubes, at least 3, is sent to the lab. And in the lab, we have 4 types of examination: physical, chemical, hematology, microbiology. First of all, physical examination. Normal CSF is crystal clear with the appearance and viscosity of water. Abnormal CSF may appear hazy, cloudy, smoky, or bloody. Clotting of CSF is abnormal and indicates increased protein or fibrinogen levels. Grossly bloody CSF. Approximately 20% of lumbar puncture result in blood samples. It's important to identify the source of blood. Now I give you some difference between subarachnoid hemorrhage and traumatic tap. In subarachnoid hemorrhage, blood mixed with all test tube uniformly. In traumatic tap, tube 1 and tube 2 more bloody than tube 3. Pressure often increase normal pressure. Blood does not clot. Blood often clots. Yellow color xanthochromia is due to oxyhemoglobin from lysed red blood cells. Methemoglobin, bilirubin, increased protein, melanin, toxoplasmosis. Fibrin clot indicate increased protein concentration and increased fibrinogen. Webbed fibrin clot in TB meningitis, traumatic fibrin clot. Clarity, normal clear, turbidity increase in the number of cells. Normal CSF clear, slightly cloudy in tubercular meningitis, cloudy in infection, turbid in acute bacterial meningitis. Now my colleague Matthias will continue.
Hi, I am Matthias. The second part of examination is chemical examination, by which we can measure many chemical products. The most important ones are glucose and protein. CSF glucose is measured by using a glucose oxidase method or by using Benedict's reagent. You can see here the Benedict's solution and the color indicates the concentration. Increased glucose is due to diabetic hyperglycemia or epidemic encephalitis. Decreased glucose is due to acute bacterial meningitis or systemic hypoglycemia. Below here is an important note that say CSF glucose must be measured as soon as possible within only 20 minutes to prevent glucolysis. CSF protein. Total protein in CSF can be measured by the following methods. The first one by using trichloroacetic acid method, and second one is by using semi-quantitative method. Increased CSF protein can be due to infectious conditions or obstruction to circulation of CSF. Decreased CSF protein can be due to hyperthyroidism or intracranial hypertension. Now we have CSF electrophoresis, and we all know that electrophoresis is a way of separating proteins by applying an electric field. Electrophoresis of concentrated CSF is used to detect oligoclonal bands, which are defined as two or more discrete, which means separated, bands in the gamma region. You can see here two diagrams of electrophoresis. The left is normal and the right is a case of multiple sclerosis disease, and the red arrow shows the gamma region, which contain three waves. These are called oligoclonal bands and they are absent in the left side. This test is used to evaluate bacterial and viral infections, also tumors of the CNS. The most important application is detection and diagnosis of multiple sclerosis disease, which is an autoimmune demyelinating disorder. That means there is antibodies that's attacking the myelin sheath around the axons. So these abnormal immunoglobulins migrate as discrete sharp bands, and this picture shows in the upper brackets to the right side there is deep stained bands. These are called oligoclonal bands and are formed by traveled IgG. These bands are found in the CSF of patients with other types of nervous system disorders of the immune system, including HIV infection. This table shows the percentage of patients with elevated IgG index, IgM index. You can see here in infections, there is 25 to 50% of patients with elevated IgG and only 25% of patients with elevated IgM. In multiple sclerosis disease, there is high percentage, 70 to 80% of patients with elevated IgG and less than 25% with elevated IgM. The last one is neoplastic disorders. There is less than 25% of patients with elevated IgG and the IgM is not determined. Third part is hematology, which means counting the cellular content of CSF sample. CSF is essentially free of cells. The major cells that can be found in microscopic examination of CSF are the following. The first ones are lymphocytes, and they are found in normal individuals in very low amount and are increased in viral, tubercular, fungal meningitis, and also in multiple sclerosis. Second ones are macrophages, which can be found in viral, tubercular meningitis, malignant cells, of course, in metastatic carcinomas, neutrophils, in bacterial meningitis. So remember, macrophages in viral, but neutrophils in bacterial meningitis. The last ones are plasma cells, which can be found in multiple sclerosis and also in tubercular meningitis. I have finished. Thank you.
I am Isra Yassin, third year medical student, and I will talk about microbiological examination of CSF, which can provide us important diagnostic information. We have four methods for microbiological examination: gram smear, culture media, serologic test, and PCR. We start with the gram smear. It should be the first investigation to be performed. A gram stain is positive in 60 to 80% of untreated cases of bacterial meningitis.
and in 40 to 60 of partially treated cases. A gram smear is required when the CSF contains post cell, so it provides useful information when a CSF is unsuitable for cell counting or biochemical testing. When Mycobacterium tuberculosis is suspected, Zeal-Nielsen stain should be performed. We see here gram stain of Neisseria meningitis, a gram-negative diplococci, and here a gram stain of Streptococcus pneumonia, a gram-positive diplococci with white BC. Now with culture. Culture done on a blood agar and chocolate agar remain the gold standard for diagnosing bacterial meningitis, but can also culture on a conky agar and fluid thioglycolide. After centrifugation of the CSF and removal some for the gram film, the remainder of the deposit should be seeded heavily into culture media. Mycobacterium tuberculosis is best grown using multiple large volume samples of CSF. Because the TB bacilli show in a small number, maybe 2 to 3 bacilli in culture, so we need large volume of CSF to increase possibility to obtain positive case. And these culture often take up to 6 weeks to replication for positive identification. Here Neisseria meningitis colonies on a blood agar plate. Here Streptococcus pneumonia colonies. Serological testing. We use suspension of latex bead binding to antibody on a slide. Then put a drop of CSF. If there is any agglutination, this indicates the bacterial antigen in our CSF sample. Here the negative reaction and here the positive reaction. There is agglutination between antigen and antibody. Tests are available to detect Neisseria meningitis, Streptococcus pneumonia, and Streptococcus agalactiae, but sensitivity varies greatly between bacteria. Now with PCR, polymerase chain reaction has been a great advance in the diagnosis of meningitis because it has high sensitivity and specificity for many infections of the CSF. It's fast and can be done with a small volume of CSF. PCR is especially useful in the diagnosis of viral meningitis. PCR is sensitive for acute neurosyphilis, but not for more chronic form. In this chart of CSF differential diagnosis, we see an increase in initial pressure in all disease as a result from increased intracranial pressure or caused by a tumor, except in multiple sclerosis is low. Appearance difference from opacent in bacterial and tuberculous meningitis, and clear in acute syphilitic meningitis. Clear or xanthochromic in brain tumor, but normal appearance in multiple sclerosis. Increase in protein in all infectious meningitis and tumor as immunity response, blood-brain barrier become more permeable and increase its amount of protein enter the subarachnoid space and appear in the CSF. Decrease in glucose in bacterial meningitis, TB, acute syphilitic, and tumor, except in multiple sclerosis, is normal. If you are interested and want more information, these are references of our seminar. And thank you for watching.